We now go on to the next battle. Gregor Möckel is going to tell us about the central compartment first, Gregor.
Okay, thank you very much, Richard. I favor the central compartment first technique. So let me start with some literature. In order to make a statement how often surgeons start in the respective compartment, we conducted a survey, and we included 32 surgeons with a total of more than 13,000 cases, surgeons from Germany, Switzerland, and Austria. And these were the results. So the majority of them is doing already the right thing. They start in the central compartment. There are still some start in the peripheral compartment, and they start where the pathology is, or they start extra-articular. So what are the advantages of this central compartment first technique? We get a very fast and clear sight in the central compartment. We can make a conclusion from the pathology inside, from the central compartment to the pathology of the head-neck area. And we have an excellent maneuverability of the instruments. This is important, for instance, for labral reconstruction or for cartilage repair. There are some risks, of course. There are potential risks of damaging cartilage and labrum, and we may need higher traction forces, which could lead to pressure damages or nerve lesions. For that, we made some biomechanical investigations. It will be published next year. We put a pressure plate behind the perineal post, and we got a 3D real-time measurement during the whole surgery, but we didn't find any difference before and after capsular release. So when you start for the central compartment first, you can put your needle onto the skin and then move it into different positions, and you can go back and do it again in order to get a safe access to the central compartment. Then when you start anterolateral first, as I do it, you can go straight to the joint space, and if you are not satisfied with the position of the tip of the needle, you can turn the tip of the needle, that the bevel of the needle can go underneath the labrum, as you can see it here. Here you see the labrum, and then you go in. I would recommend to use the air contrast. You see it here without air contrast, and then you bring in some air, and maybe this needle is too close to the labrum, but you can correct it before you go in with the guide wire. And you see the labrum, you see the perilabral sulcus, you see the peripheral compartment, you see even the zona orbicularis. So this is very helpful with the air contrast. And you should keep in mind the angulation of the needle. If you go in with your spinal needle first, and you change the position for about 5 degrees in a maybe 12 centimeters thick soft tissue, it will have a difference at the tip of the needle of about 10 millimeters. And there's another thing which is important, the diameter of the needle. Here are all the big companies and the diameters of the needles. The thicker the needle, the higher the maneuverability in the soft tissue. Or the other way, the thinner the needle, the more difficult it is to move the needle in the soft tissue into a different position. I like to put in, as a second step, a needle into the posterolateral portal, just to let some fluid out, or to suck some air in to get a very fast and clear sight in the central compartment. This is a very easy step. You see the needle coming in like this. And then at a third needle or the second portal, I like to use the anterior portal, and you can use these guide wires if you like. So in conclusion, ladies and gentlemen, before you start with the surgery, to do a test distraction, check your C-arm, check your setup, then you can simulate your portal on the skin with the needle many times before you go in. Then you feel the resistance of the capsule when you go in, and then you should use the air contrast. And once you completed all these steps, then you are safe to start central first. Thank you very much.
Okay, Gregor.